Hi, this is Dr. Poole with another Pathology Chalk Talk. This is the first of two talks about CNS infections. This talk is about the pathology of meningitis and brain abscess. Well, some of this material may overlap with the microimmunocontent. I just want to highlight some of the few basic clinical pathological issues relating to meningitis. I'll leave the details of the rest of the information about microorganisms to the capable and knowledgeable hands of Dr. Richards. The etiologic agents causing bacterial meningitis vary with the age of the affected patient, his or her immune status, and whether the infection is acquired in a community setting or nosocomial setting. Thus, knowledge of common pathogens in various clinical settings is crucial. So you need to be aware of the patient's age, their immune status, and the setting in which the infection was thought to occur. And this is not only important, it's crucial for mastering this particular topic. Meningitis is a term that is shorthand for a set of symptoms indicating meningeal irritation and suggests meningitis or subarachnoid hemorrhage. The classic triad of symptoms of acute bacterial meningitis consists of fever, a change in mental status, and neck stiffness. Although a significant number of patients don't have all three features, virtually all patients have at least one of the findings of the classic triad. If you include the physical finding of nuchal rigidity, almost all patients have two of the four classic signs and symptoms of meningitis. Headache is also common, which is typically described as severe and generalized. Nuchal rigidity is present in about 90% of patients on initial examination and may persist for more than 7 days in some patients, despite overall improvement. Some other important clinical signs are Koenig sign, Brudzinski sign, and jolt accentuation of headache. I'm not going to go into more detail on these, but you can find examples of these on YouTube if you just do a search, or I'm sure you'll be discussing this in the clinical skills portion of this case. In patients who die of meningitis, the brain is surrounded by creamy yellow or green pus. Pus is first visible at the base of the brain as thin creamy lines that extend along meningeal vessels. These vessels are engorged and stand out prominently. In fulminant cases, pus may also be noted within the ventricles, which is called ventriculitis. So this is the typical gross appearance, which you would find at autopsy. This is the brain exposed. And you can see on the surface this thick layer of suppurative exudate, that is pus, which surrounds the brain. With ventriculitis, the ventricular system is dilated and coated by a thick layer of exudate. This is a brain that has been fixed, so the exudate has this tan brown crumbly type appearance that's outlined by the arrows. Microscopically, there's no big surprise. The predominant inflammatory cell is neutrophils, and these are located in the subarachnoid space and perivascular space, which is called the Virchow-Robin space. Leptomeningeal veins may also be infiltrated by neutrophils, which is called venulitis. So this image shows the pia and arachnoid layers of the brain meninges. There's delicate strands of fibrin, indicated by the letter F and the arrows, that can be seen traversing the subarachnoid space, connecting the pia and arachnoid layers. There's a small vessel that can be seen in the subarachnoid space, and the penetrating vessel is also seen, which is surrounded by perivascular space known as the Virchow-Robin space. And this is a helpful reminder of that oops, this is wrong Robin. Hold on. This is the space, these are the guys that the space is named after. Rudolf Karl Virchow, he was known as the father of pathology. His name's all over the place. And Charles-Philippe Robin, he is a French neurologist and pathologist, and these two independently discovered this perivascular space by examining cases of meningitis at autopsy. And this is characteristic. The neutrophils are present in the subarachnoid space to the left, extending into these perivascular spaces, the Virchow-Robin spaces. This is classic for meningitis. Again, the main cell type involved are neutrophils. I also have to briefly mention aseptic meningitis. This is a benign, usually short-lived syndrome of meningeal inflammation that is not caused by any of the common bacterial pathogens. A wide range of viruses can cause aseptic meningitis. There are some much less common causes that include some bacteria such as syphilis and Lyme disease, non-infective inflammatory disorders, tumors and tumor-like conditions, and drugs such as ibuprofen. And the pathology is distinctly different from that found in acute bacterial meningitis. Since aseptic meningitis is by definition benign, reports of the neuropathologic findings are uncommon. Occasionally, patients with aseptic meningitis die as a result of a concurrent systemic illness, such as viral myocarditis, such as in this case. Histologic examination of the CNS then reveals a scant infiltrate of lymphocytes in the meninges and in the perivascular space surrounding some of the superficial cortical vessels. So again, acute bacterial meningitis, predominant cell is neutrophils. In aseptic meningitis, the predominant cells are lymphocytes, and they're much more scanty in comparison to bacterial meningitis. The other topic in this presentation is brain abscesses. Brain abscesses may occur in any age group. Predisposing conditions include acute bacterial endocarditis, congenital heart disease with a right to left shunt, chronic pulmonary disease, dental infections, intra-abdominal abscess, and urinary tract infections. Signs and symptoms in an individual patient depend on the location of the lesion, but most often include headache, nausea, emesis, alterations in consciousness, seizures, and motor weakness. Fever and evidence of a systemic or local source of infection may or may not be apparent. There's really not too much new here for you pathologically. You've seen abscesses now in other organs, and they all pretty much appear the same. This is a well-developed abscess and appears similar to abscesses in other organs that we've already learned about, such as in the lung and liver. This cavity would be filled with pus and necrotic brain tissue and is surrounded by a dense fibrous gliotic capsule. Abscesses begin as foci of cerebritis, which is characterized by collections of neutrophils associated with necrosis and edema. That's what's shown in the top panel and encircled by the blue circles. The bottom panel shows where a later stage where neutrophils from these small foci start to coalesce and consolidate into larger areas of inflammation in which the neutrophils are eventually replaced by macrophages and lymphocytes. In the final or capsular stage shown in the bottom panel, granulation tissue in the yellow oval surrounds the area of inflammation outlined in red, and this eventually turns into a fibrous capsule which is at the bottom of the image, which is composed of gliotic edematous brain tissue. Alright, so let's add things up here and summarize what we've learned about in this presentation. Meningitis is characterized clinically by the signs and symptoms described as meningismus. Grossly, the brain is surrounded by pus, first visible at the base of the brain and often following along the distribution of the meningeal vessels. Microscopically, acute bacterial meningitis is characterized by neutrophils in the subarachnoid space and perivascular or Virchow-Robin space. Brain abscesses are characterized grossly by areas of pus or suppurative exudate surrounded by a fibrous capsule. Microscopically, they progress through a series of stages. Early, you find cerebritis with collections of neutrophils. In the intermediate stage, the neutrophils are replaced by macrophages and lymphocytes. And then in the late phase, there's necrosis and purulent exudate surrounded by granulation tissue, a collagenous capsule, and gliosis. So thanks for your attention.